Hi, everybody. I'm sure most of you probably saw the news story about a tragedy that happened in a dental office back a couple of months ago. So I actually brought in our pediatric dental anesthesiologist. Her name is Alexi DeFreitas. She is fantastic and has been doing sedations at our office for several years now. She does a fantastic job. It makes me feel comfortable that our patients are safe, which is most important. So I hope you find the interview really informative. I hope that if you have, whether you and your family are considering needing to do a sedation at some point, or if you've got family members or grandkids where an anesthesia appointment might be on the horizon, then I hope you find it informative. She goes through all of her protocols, everything that she does, her exact medications that she uses. So I'm just really grateful that she was able to take time out of her day and speak with me. So I hope it's super helpful. And if you guys have any questions at all about sedations in general at our office, anything like that, then the team I know is going to be on and will be happy to answer those questions. So miss you guys. The next time that I see you, it will be like T minus hopefully days to opening the Frisco office. So I'm super excited about that. Construction is well underway, more than halfway done, and they are trucking right along. So excited to be able to open up in Frisco and see some of you there as soon as September, hopefully. I am just honored and pleased to have our very own anesthesia provider for our pediatric patients to join us. What we really want to do is just talk to Dr. DeFreitas about what we do and why we do it when we're handling anesthesia for our pediatric patients in our office. So, Dr. DeFreitas, I'm so excited to have you. Glad to have you here.
Yes, thank you so much for having me.
Absolutely. So can you tell us just kind of briefly it, how you how you got to do anesthesia? What are your credentials? What type of education do you have? All that good stuff.
For sure. So, I am a anesthesiologist, which just means that I went to dental school. And then after dental school, I completed a 3-year anesthesia residency. So, prior to that, I did a 4-year undergrad at Rice University in Houston, and then came back up to Dallas for my dental school, which was at Texas A&M College of Dentistry now. And then I went to Pittsburgh for the 3-year program for anesthesia. So they have a really nice program that's incorporated with the UPMC hospital system, as well as the University of Pittsburgh Dental School. So we spend half our time in the hospital, in the ORs, and then the other half we're doing cases around the dental school in different disciplines, especially pediatrics. We actually do see a lot of patients who have special needs as well. And then we also do a rotation or different rotations, but one at the Children's Hospital where we spend a few months just solely doing pediatric anesthesia, as well as a month in the Children's Emergency Department in Pittsburgh as well. So we've kind of trained all over the place, done anesthesia for all types of cases, but it's mostly so that when we get out and we're doing just our dental cases, we have the background of how to manage more complex situations or patients and things like that. So I've seen tons and tons of kiddos for sure and love it.
So does that mean that your training is in sedation for all ages?
Yes. So we can see pretty much any age range. I have seen teeny tiny little newborn or preemie babies in the hospital in the OR. Of course, we're not going to be seeing those kiddos in the office, but um, I've seen patients of all varying ages, even up to early 90s. So very broad range, but now I would say the bulk of my patients are either pediatric patients or patients who have special needs. So that's about 75%, I think, of what I do and the patients that I see.
So what's the difference between a dentist anesthesiologist and a regular dentist who does anesthesia?
So someone who's uh, a dentist anesthesiologist has to have completed that 3-year anesthesia residency. There are, I believe, now 11 across the country. Whereas a dentist who provides sedation, they have either done a different residency where they were trained in oral sedation or IV sedation, or they've gotten extra training through CE courses. So the anesthesia is, in general, is just a spectrum from awake to completely asleep. Being sleepy for a procedure where you've either taken a medicine by mouth or maybe you're getting some medicine through the IV, but ultimately you're going to be more awake versus what I'm going to do. Especially for our kiddos, you're going to be completely asleep under general anesthesia, and we'll be monitoring all of the vital signs during that time to make sure that you're also staying asleep and not aware so that we can get the treatment done.
Yeah. So definitely different than our other team that provides IV conscious sedation on our older teens and adults. That is a different thing. So when we're doing kiddos, it is a true anesthesia where they are asleep and not, um, they're not able to wake up during the procedure or anything like that because you're making sure that they're sleepy enough, but obviously not too sleepy.
Correct.
Not sleepy to the point where it's dangerous for them to be. So
Exactly.
and I get asked this a lot. A lot of people will ask, well, why can't you just do the anesthesia? Asking me, why don't I just do
Yeah.
anesthesia? Why doesn't Dr. Sean do the anesthesia? And why don't we do, because there is, kind of that mid-level, that oral sedation, which is part of the issue with the case in Fort Worth. And this is one of the big reasons is because not that it's not comparable, but this is one of the reasons why I don't do sedation and why I for sure don't do oral sedation anymore. I did earlier in my career. I feel like, for one, with oral sedation, it is less predictable. A
Yes.
child may react in all kinds of different ways, all varying levels of sedation to the dose. And I don't want the stress of having to deal with a child who's not sedated enough. And then we've done all of this time and effort and prep to get to the appointment, and they're still not sleepy enough to be able to get the work done. That's terrible. Or the opposite is even worse. If they have maybe a little stronger reaction than we wanted and they're sleepier than what I'm comfortable or trained to handle. We don't want either of those. So I definitely don't like oral sedation for those reasons.
Yeah.
And I want to make sure that patients are monitored and that somebody has their focus 100% on their kids' safety. Um, I just want to do the dentistry. If a
Yeah.
child is sedated, I don't want to have a split focus where I'm doing the dentistry and also checking vitals. So
Exactly.
that's why I personally don't do it. And if we're going to have sedation done in the office, then we're going to do it with the right team, the right monitoring, the right protocols in place.
I do actually get asked a lot if we can do the oral sedation. And a lot of what you said is also my answer, where I have been trained to start an IV to use more advanced airway techniques where it's more predictable. I can control a lot more of the level of sedation. Because when you do the oral sedation, exactly what you described, you kind of are going to get the effect you're going to get. And if it's not enough, there's not anything you can do at that point other than reschedule or and then call us in or something like that. So if I'm there, my goal is to just make it so that your child is very comfortable and the dentist is able to work. And my focus and everything that I do is solely regarding the anesthesia and I also don't have to worry about doing the dentistry. So I get to just focus on the anesthesia.
So when's the last time you did a filling?
Probably 9 years. I actually went straight from dental school into my residency. And so I will do minor things like cleanings every now and again. But really and truly, I have not done an actual filling or crown prep or anything like that in pretty much the 9 years.
Which is good. That's exactly what we want.
Yes,
Somebody
exactly.
who does anesthesia all day, every day. So that hopefully your job is 99.99% really boring and predictable.
Correct.
Yes.
Exactly. It's often compared to flying a plane, to where the beginning and the end are the most active parts for us, but in the middle should just be very smooth and monitoring the patient.
So walk us through what actually happens during that sedation appointment. Kind of take us start to finish.
For
What is
sure.
happening with the kiddo?
Yeah. And so the very first introduction you're going to get is probably a phone call from us going over all of this information as well. And the biggest thing is, of course, we're not going to want the kid to have anything to eat or drink for the morning. And so when you guys arrive, I'll come out, make sure that that's happened, that we didn't have anything to eat or drink accidentally. And as take a listen to your kid's heart and lungs, make sure their lungs sound clear, there's no congestion or um, anything along those lines where they might be sick, or I'm also checking their heartbeat rhythm, making sure there's no murmurs and things like that. So I'll probably come out, introduce myself, try to, ease the tensions a little bit, talk to your kiddo, tell them that we're going to do some magic juice or princess juice to make them sleepy. And so that medicine is midazolam or Versed, which is of the drug class of benzodiazepines, which for adults, they usually will take like Valium or Xanax. So it's that same anti-anxiety classification, to where it's really just to help your child or the child relax, feel a little bit sleepier, and kind of remember that falling asleep feeling in the waiting room with mom and dad there. Typically, the medicine takes 15 to 20 minutes, sometimes maybe up to 30. So once that's taken effect, then we'll go back to the procedure room, and we'll actually have your child breathe the anesthesia through a little face mask to fall completely asleep. So that way, they're not having to get an IV or anything like that when they're awake. So we'll go back to the room, get our monitors on. Those are the blood pressure cuff, the EKG monitors. So we monitor the heart rate and rhythm the entire time, and the pulse ox to monitor oxygen, and then ultimately the breathing tube, which will help monitor breathing. So once they've inhaled that anesthesia, they'll fall completely asleep. And then that's when I'll start the IV, and we'll secure that breathing tube in place, make sure it's exactly where we want it, to where your child's both lungs are breathing nice and equally. So after that time, we will let the dentist work. Then once they're all done, that's when I get to jump back in and then start that wake up process. One of the other big questions I get is, how do you wake them up? And so since the medicine is just inhaled, most of it is just allowing your child to kind of breathe that off, breathe just pure oxygen, and that'll eventually like wash the anesthesia gas out of their lungs, and they'll start waking up. We do use some other medicines that are going to help with pain and kind of calming to help kiddos wake up a little bit more gently. And so once we've removed the breathing tube, I will actually watch your child probably another 20 or so minutes, make sure everything's going exactly as we expect, and then move them to recovery, which is when we'll bring you back. So a lot of parents also say, well, can I be there when they're waking up? And um, of course, but that is once we have moved to that recovery room. And so in that interim period, the child's not going to remember really waking up if they happen to open their eyes and see me. So kind of the first thing we want them to see when they're getting up is you. So we'll get you back there pretty quickly. A lot of kiddos do tend to wake up just very grumpy, upset, and crying after anesthesia. So it's definitely a harder day, especially for mom and dad. A lot of times the kiddos don't remember any of that at all. But it's just, the anesthesia effects, of course, are going to make you feel a little disoriented, dizzy. A lot of kids don't love if their mouth is numb, and that's all new sensations. And for a little 3 or 4 year old, the way they express themselves is through tears. So it tends to come out as tears. But in the anesthesia world, it's kind of a bad joke that crying at least means they're breathing. So usually if they're crying, it's okay. We just kind of reassure them, let them know, hey, everything's all finished. We're going to go home. You'll go home. It's definitely going to be a lazier day. Your kiddo's probably going to take a nap for a while, want to stick with the softer, blander things, especially in case their stomach's a little upset. But then usually by dinner time, they should be up and a little bit more back to themselves, and definitely by the next day, because everyone always wants to know, can we go to school the next day? Things like that. And the answer is yes.
I know parents ask us, and I'm sure they ask you. So you already said the princess juice,
Mhm,
the anxiolytic, the anxiety med that they take at the beginning is Versed or midazolam.
mhm.
And then what kind of medication are they breathing? What's the actual anesthesia?
So the medicine that they breathe is called sevoflurane. It is the same anesthesia gas that is used all over the world in hospitals. Um, and usually once we're going to sleep, it kind of has the sweeter smell, but kind of a very distinct smell. So that is actually going to keep them asleep the entire time. But I do still get the IV, as well as give a few medicines via the IV, but it's also there for safety, of course, right? So, like we've said, we're monitoring their breathing, we're monitoring their heart rate. So, one of the first medicines I give through the IV is called glycopyrrolate, which it actually is to help boost their heart rate as well as help dry up some of the saliva and other secretions, just so that when they're waking up, they're not having a lot of gunk that they're unable to swallow, basically. The other medicine that we'll give right away is Decadron, which is a steroid. It is actually going to help with some of the inflammation, swelling, mostly for our end with the breathing tube, of course. We're introducing something foreign into the body for a brief period of time, but sometimes that can cause a little bit of a inflammation reaction, as well as if we do extractions or anything, it's going to help with some of that swelling in the mouth. And it provides also the anti-nausea, anti-vomiting effects that we want, just because the anesthesia gas itself is a little bit nauseating afterwards. So everybody responds differently. You hear all these horrible stories in the news, but we are giving it in a very controlled, small quantity. It's titrated actually to your child's breathing. So, obviously, we don't want your kid breathing too fast and hyperventilating to where they're not able to get enough oxygen, but also not too slowly. And so we give just small doses throughout. It helps with some of the pain control as well. And so that's just going to help in the waking up process to try to help control like that pain and any other feelings like that. And then we also will give Toradol, which is more of an NSAID type pain medicine in the IV. And so that one is to help last, or about it lasts about 6 hours, and it's to help too. Sometimes there's a little bit of a sore throat from the breathing tube, things like that. The fentanyl we give actually only lasts about 45 minutes to an hour. So by the time you're leaving the office, it's most likely already been broken down by your kid's system. So then that way, that Toradol is there to kind of help in the going home. And if they're not up for eating and drinking right away, you're not worried about pain at that point. And then the last medicine we usually use is called Precedex or dexmedetomidine. It's a really great medicine. It's a sedative agent, and it has helped tremendously in smoothing out some of that postoperative crying and just agitation, to where kids are just so upset. So it actually just helps mimic natural sleep a little bit and just smooths out that experience. And so that will kind of help keep your child a little bit sleepier, which is also why we have the extra monitoring afterwards. But it's been one of the greater medicines that we've been able to add to our toolbox for making it a more pleasant experience.
I would say for our patients, especially my more holistically minded,
Hmm.
It's a lot of medications.
Hmm.
Like a lot of different things. Each one has a specific purpose. Each one has a role to play. Each one is very, very carefully titrated and measured and used in exactly the right amounts, not too little, not too much. And so I think this is one of those areas where if we're at the point where we need to do a sedation, we want to do it right. And we want to make sure that your child or your special needs child has the best experience they possibly can. And it's really a combination of meds that help us get
Hmm.
that as gentle and smooth of an experience as we can get. So I would encourage parents and say it's a short period of time. And then we're going to give them all the good stuff they need on the back
Yeah.
end to make sure that we process all those medications and we get them back to baseline as quickly as we can. And then when so you give the anesthesia, you have the IV, and then you wake them up just by turning off the anesthesia meds that they're breathing in and then replacing that with oxygen. Is that right?
We do use oxygen nitrous. I forgot to mention that with our anesthesia gas. So the nitrous is the laughing gas. I think most people kind of know what that is, but it actually does help a lot in the body's uptake of our anesthesia gas to make the falling asleep initially happen a little bit more quickly. And so once we discontinue those gases and exactly what you said, or just giving the oxygen, it's kind of flushing out the other gases from their lungs and they're essentially just breathing it off. And then we'll start to wake up after that. It's usually a pretty um, routine amount of time, I would say, where within 5 to 10 minutes, I expect most kids to at least be, waking up a little bit, responding to some things, but still sleepy and groggy because, of course, we still have some of our IV medicines on board, which is what they're there for. But ultimately, any medicine we give, the IV, the anesthesia gas, your body is essentially going to start trying to break those things down right away. So, especially the IV medicines, from the time they get it, you're already going to start metabolizing it, breaking it down, trying to clear it out of your system. And so sometimes those breakdown products are also what's going to hang around to keep them a little bit sleepier. But ultimately, in terms of waking up from anesthesia, it is just turning off that gas and kind of a thing that I guess came up in that case, which of course there are reversal agents in the unfortunate situation when somebody's not waking up as quickly as you'd like or something like that. And we carry those, have those. But my personal goal is to not need them. I just like to let the medications work as I expect them to and let them wear off naturally.
Yes, I love that. I could say what, because families will always ask, especially families where the kiddos got a lot of chronic illnesses that they're working with.
Mhm.
We have a lot of patients with either mold illness or Lyme or things that just health issues that they're working through. And so we do what we need to do, making sure that we've got the proper clearances. If we're needing to talk to a physician
Mhm.
ahead of time, we're talking to that child's physician ahead of time. Um, and so far, and as long as it's been safe to do a sedation from a medical standpoint, usually my super smart functional medicine doctors that are treating my patients, usually what they will tell me is they'll say, Dr. Tony, you guys do what you need to do. And then on the back end, I'm going to make sure that they're supported with nutrients that they need to help
Mhm.
clear everything out. So, like their antioxidants, like vitamin C, they're going to want them taking probably some liposomal glutathione and maybe some methylated B vitamins. Again, those aren't protocols that I'm putting patients on. That's for their functional medicine doctor or their pediatrician to do. But that's typically what we're seeing as a way to support the body, help the body process the medications the way that it should as quickly as possible. So they, again, get back to baseline as quick as they can too.
Yeah. And we have every now and again patients ask us to give them the list of medicines to give their functional medicine doctors. And so that's something we can always do. And I've also had the experience where they've never really, all of our medicines, I should say, are just typically approved by them anyway. So there's not really much concern for the medicines we use. And so that way, that at least everybody's kind of working as a team so they know what your kiddo is going to get so they can give you the correct medicines for afterwards as well.
Absolutely. You said a couple of times that you're inserting a breathing tube.
Mhm.
Tell us a little bit about that because sometimes that surprises parents.
Yes.
What exactly are you doing with the breathing tube and why is that important to do?
Yeah, so that breathing tube is there for two purposes. One, we've already kind of discussed, which is the continuing to administer the anesthesia, but as oxygen as well. And the other is to protect the airway. And so, um, in the anesthesia language, there's always the unprotected versus protected airway. And it actually leads to some questions about like general anesthesia, where people automatically think that means you're using a breathing tube, but it doesn't actually have to mean that. However, we like to use it because one, we're working in the mouth, there's a lot of water happening. And so we don't want that going down into anybody's lungs and for kiddos to, accidentally aspirate that into their lungs, which can lead to infections later on. So that breathing tube is there to help close off the airway so that the water and any other debris wouldn't be able to get down into their lungs, but also we're able to administer our gases. I can use our breathing bag or ventilation bag to help them breathe if I really needed to. However, kids are actually breathing on their own through that tube. So it also doesn't mean that they're on a ventilator. It doesn't mean that they're paralyzed. We don't use paralytics for our kiddos. Like I said, we just like for them to be breathing naturally on their own, just if supported through the tube if we needed to. Of course, there are times where they're going to be sleepier, and we want that, right? When they're falling asleep, things like that. So we're also very trained in supporting their breathing and maintaining their ability to breathe. So that's all a part of using a breathing tube and being trained in using a breathing tube.
I've worked with anesthesia providers who have done it both ways now,
Hmm.
with intubation and without. And when I'm working with somebody who's intubated, then it does make my job faster and honestly less stressful for me as the dentist. When we're working on somebody with either a conscious sedation or a kid who's not intubated by the anesthesia provider, um, we're having to all be more vigilant because the anesthesiologist is having to be more vigilant about the airway. So we're frequently having to stop and make sure that the airway is in
Hmm.
an position. We're having to be much more careful that no water is getting where water shouldn't get, or saliva or blood or anything. So it is one of those extra layers that helps protect the child and helps us go faster, quicker, do better dentistry in a more efficient way, which makes the anesthesia shorter, which is what we want. We want quick, we want efficient, we want to do a good job and get
Definitely.
done. So I'm a fan now of intubation.
Me too. I mean,
Right?
we also do both.
Yeah.
And exactly what you're describing. It's like there are, of course, risks and benefits to either one. But I would say definitely for kiddos, they don't have quite the same oxygen reserve that maybe an adult has. And so it's also another layer of just reducing the amount of time that maybe they're not breathing or not getting oxygen. And so it is definitely my preferred route for kids.
Correct me if I'm wrong with the inhaled anesthesia medicine. I know with all the oral meds, what you're most worried about, like what can go wrong first in a
Hmm.
sedation, is over sedating leading to respiratory depression.
Yep.
You lose respiration, you lose the ability to breathe properly, and then it becomes a situation you have to handle
Correct.
quickly. Like then it
Exactly.
becomes a problem. So
Yes.
anything you can do to prevent that from even being an issue in the first place or help us correct it quicker if
Oh,
something is going wrong.
definitely. Yeah, because I think a lot of people um, don't realize that even if you are planning to do an anesthetic without a breathing tube, that is always the backup. That is the emergency, like exactly the plan of what you're going to do if the first thing that you're going to worry about is if someone's not breathing, they're not getting oxygen. And so the easiest way to do that is to have the breathing tube there. So there's other devices that are used and we can use, but kind of just already opting for that breathing tube is, in my opinion, not this necessarily that it's the safest. I just feel the most comfortable having that already in place.
Totally agree. Totally agree. So in the room itself, the treatment room in a dental office gets crowded because you've got a lot of equipment. Your team is there, my team is
Yes.
there, and all of our equipment. So I know I have all of my normal dental stuff,
Hmm.
myself, the patient,
Hmm.
my chairside assistant, and then usually somebody in the hallway who can run fetch stuff quickly if we
Yes.
forget something because we're trying to work again efficiently.
Yeah.
And, and what all do you have in the room, equipment wise, team wise? Who do you bring?
Oh, sorry. I bring an assistant with me who is also there to help hand me things quickly. So in the room itself, which if you come back with your kiddo, I'm going to call it the elephant machine, where it's going to be their anesthesia machine with the tubing that's going to help connect from the breathing tube to that machine that's supplying the oxygen. And so that's there. We have all of our monitors. So we're also doing heartbeat and blood pressure. So we're seeing beat by beat, breath by breath, what's happening. So that's there in the room as well. And then we do have our emergency medicines on hand, as well as any like alternative breathing devices that we may need. We use a video camera to help see down the airway when we're intubating. And so we have all of those things readily available. And so my assistant is also there so that, especially because that room is things and trained in what I need and things like that. So, um, ultimately, it looks like a lot of stuff. It looks like I'm moving in if you ever see me coming in to set up, but it's all the things that I need to keep your child asleep and safe and get everything done in a predictable and safe manner.
Okay,
Perfect.
so tell us, do you allow parents in the room during sedation?
Yeah, so this is a very common question that we get, and parents are allowed to come back while we're getting their child off to sleep, um, and that's kind of the process of using that mask on their face to help them fall completely to sleep. And so um, that is fine. Usually, if you want to be there, I do typically forewarn parents what to expect because it does have kind of a stronger smell. Kids are, of course, going to try to kind of pull that mask away or turn their head. And so, usually, we're just, have a firm grip so that they're the only ones breathing the gas. We don't want to fall asleep as well. But typically, I usually say it's about 10 breaths and kids will start falling asleep. And then after that point, we will have you wait up front, mainly because that's the time when, like I said, all of my fun happens. And that's when I'm going to be the most focused on making sure that I'm getting that IV exactly where I want it, the breathing tube placed and secured where I want it. And so I am completely unable to take care of anyone else in the room but your child at that point. And so it's safer for everybody, I think, if we have parents wait up front for that time. And then that way we're able to get the treatment done and then get them back as they're waking up. And so it's similar to the hospital. When kiddos go in for surgery, it's the same. They typically will allow you to go back while your child's falling asleep. And then once they're asleep, they'll have you wait up front. And so we use that same policy for the same reasons. And it's, like I said, just keeps everybody safer. We do, however, have parents who I explain all of that and they decide that they would rather not be there for that, and that's fine too. So don't ever feel like, or at least for parents to not feel like if they're not there, your child's going to be afraid or anything. Like one, that's why we give that anti-anxiety medicine to start. We're also playing a show or something on the screens to help distract them. Like we definitely try to use kid-friendly language and terminology just to make it less scary. So I always joke I'm a big kid at heart. So a lot of the stuff we say sounds childish and that's intentional. So um, again, it's also a very quick process, quick within, like I said, 10, 15 seconds. So usually kids don't even remember if you were or weren't there. So, um, but again, there's lots of studies that show it does help for mom and dad to be there while they're going to sleep. And so um, we are fine with that.
Awesome. I love that. And you guys do, like you and your team, for one, it helps that you're young and cute and fun.
Oh, thank you. Thank you.
So, so kids are usually just fine going back with you. I've seen little kiddos just like hold your hand and
Oh,
walk
yes.
back there. They're usually a little like sleepy already from the princess juice by that point,
Yes.
but they walk back, they're enjoying life. They've got like a little teddy or lovey or something that
Yeah.
them. And so that process is usually pretty easy and straightforward. Honestly, your explanation is probably sweeter than mine is because I come at it from because my kids are teenagers. So I feel like if I'm talking mom to mom, I'm like the old mom who's talking to the younger mom. And
Hardly.
it, I absolutely think that parents have a right to
Hmm.
consent to treatment and consent to anything that's being done with their child. I think a parent should be in the room when it's best for the child and it's
Hmm.
safe. And that's why there are only two scenarios where I don't allow a patient in the room. And it's those sedation cases and it's the infant tongue tie cases. And that is because I want to be focused on your child. And
Hmm.
times where mom and dad can get emotional,
Hmm.
or their emotions can impact how the child is doing. If it's a situation where the
Oh,
child's
absolutely. Yeah.
then I don't want to have to manage both of you.
Correct. It's the truth.
Lovingly.
Yes.
Lovingly. I don't want to have to
I
manage both of
Oh, yeah, absolutely. Through our residency, we had a rotation through the women's hospital where we would do the epidurals. And, we would have the partner, whoever emotional support was there, sit. And so once it was a surgeon, he was adamant that he was going to be fine. He didn't need to sit. And of course, as soon as they started the epidural, he fainted because it's very different when it's your own family member.
you.
And
Is.
so I think sometimes people aren't aware how they're going to react. And like I said, it's like we don't have the time in that moment to take care of two people. And
Yes.
my priority, of course, especially at that point, your child is asleep under general anesthesia. So I
Mhm.
absolutely cannot deter and take care or lose focus. So it's really, again, what's in everybody's safety and best interest.
For sure. And for anybody watching if you guys are not our patients, or if you're watching from somewhere else afar, I 100% believe that you need to be able to trust your providers. If you don't feel comfortable letting your child go back into the room with a provider, I I understand, like you should listen to that, but I can tell you if we haven't built up enough trust with, as our patient, if we haven't built up enough trust that you trust us with your kiddo to go back and go into the room without you or to, complete the procedure without you, then none of us have done our job and
Mhm.
we shouldn't be proceeding. I want to make sure that kiddos are safe and well taken care of. And parents and patients absolutely have to be able to trust the provider to be able to do that. And if your gut's telling you you can't trust that situation, you have to listen to that and you've got to pump the brakes a little bit.
Oh, absolutely. And I think sometimes parents feel that them being there is going to be the safer thing. That, if something were to happen, and I get that, like they think they're going to swoop in and
Sure.
help. which it's again, we're all going to be very focused on managing that situation. And so it is one of those times where you have to be able to trust the training of the people in the room to take the best care of your kid.
Okay, so we're gonna the not so fun parts for just one little bit, and then we're gonna not
Mhm.
talk about the bad stuff anymore because most
Of
of it's all
course.
good. When do you start to become worried? And at what point is a worrisome situation an emergency?
So it's, it's a lot of training, I think, where I've seen a lot of things. So there's a range of what we expect, right? So kids naturally have a faster heartbeat. And so I expect it to be high, and so numbers that would be dangerous for an adult are completely normal for a kid. And so once that starts trending down, I'm going to start intervening. And that's why we have the monitors there so that we're watching everything in real time and can be proactive. Because I think, like, the question is, when does this become an emergency? It's typically because it went unnoticed or unrecognized. And so, kind of having that surveillance and early intervention is going to help prevent a lot of those things. Again, we're monitoring the breathing. There are risks to everything that we're doing. Of course, we're always going to do something where the benefits are going to outweigh the risks. And I think we've talked a lot about the benefits of using the breathing tube, but there are some risks associated with that. And so, again, we can monitor that breathing pattern. If we start seeing changes, the kind of frequency or volume of those breaths decreasing immediately, especially like a lot of anesthesia is very systematic where you do things the same way every time. And so you have different, mental lists you start running through of why is this thing happening? So, I mean, everybody has extra heartbeats. That's a typical everyday occurrence for everyone. So we may see that under anesthesia, and it has a certain sound on the monitor. So even if I'm not looking directly at that monitor, my head is immediately swiveling to see, like, why did that sound change? And so just really nuances like that again are why it's nice that we're there to monitor only that, because if you're drilling, you're focusing on doing a billing or something, you may not notice that. Whereas I'm there, I'm watching it. And then if those things start increasing, again, that's when I'm going to start, you know, being a little bit more concerned, seeing if I need to give a medicine to help or anything like that. People ask often, like, what are the things we worry about? And it's going to be something heart related, breathing related, especially for kids. Their oxygen level is kind of a really big driver of everything, including their
Changes
heart rate.
fast, right?
Yes. And so, as soon as you start seeing, like, if they, for some reason, their breathing's getting slower, like, I can give them breaths through our anesthesia machine, things like that. And so, we're there for that. Of course, we have the emergency medicines on hand to begin treating most of the things we could expect. Rare things happen very rarely. It's always kind of what we say. And so, one of the bigger risks of using that anesthesia gas is a disease known as malignant hyperthermia. And I always say that's kind of the biggest emergency I think that we can encounter. We haven't discussed it, but we are monitoring temperature in your child because one of the early signs of that is a rise in temperature, as well as some other things that we would see on the monitor. And so we have, again, the medicines to begin to treat that. But in those types of emergent situations, ultimately, we're going to call emergency services, do what we can in that interim time to start treating those things, and then ultimately let them take over. Um, However, fortunately, anesthesia in the office is very routine and safe under the right circumstances. Because I know we've talked a little bit about medically complex kids, things like that. And so, getting the appropriate health history, appropriate like recent illness history, making sure they don't eat and drink, those are the things that could alter your plan or expectations. And so sometimes people think we're like really harping on it. or if they try to give me like a vague answer, like, did they have anything to eat or drink? Without realizing it, it's actually critically important because another one of the big things we worry about is anything regurgitating through the lungs or through this from the stomach into the lungs. And so, if there's nothing in the stomach, that's going to greatly reduce that risk. And so, it is actually very, very important to follow those guidelines. Again, the monitoring is the biggest help in preventing those things. There's, lots of old adages that you can watch the patient too and stuff, which of course we're doing that as well. We're actually also, we're making sure our pressure points are padded and things like that. So there's not nerve injuries. So there's a lot of different things that we monitor all throughout the procedure to try to help prevent those emergencies from becoming emergencies. So I like to say, that there are things that are urgencies that I am trained to deal with, and that my training helps prevent them from becoming emergencies. Whereas sometimes people who have different training in moderate or the IV conscious sedation, they learn that these things are emergencies and they, like I said, they are urgent. However, we have a little bit more training to kind of manage that more smoothly, to where again, having the breathing tube already in place, things like that, those things really help.
That's a good way of explaining it. Generally, it worrisome symptoms. I, as a general dentist, am going to call EMS. I'm going to call 911 faster, probably,
Yeah.
than you would, because you have the training, the tools, the medications to handle situations up to an extended point, far more than I do. And so I'm going to be calling far earlier just because of the limited training. I have emergency training, we have CPR training, all of these things are emergency protocols, but we don't have the medications.
Mm-hmm.
I can tell you, I have never intubated someone, and thankfully I've never had to give any kind of reversal medication to someone. So was I trained to do it? The reversal yeah, I was trained to do it, but I've never done it. So 911 call is going to go first.
Yeah. And I think too, and a lot of it, because I know too, we'll talk about like training and kind of simulations within the office and stuff. And so sometimes a lot of what goes wrong is just people get stressed. Of course, it's going to be stressful, and then your brain stops working. Whereas a lot of this stuff is ingrained. I always kind of joke like I can do a lot of things just with my eyes closed by sound or feel, which I would never obviously do that. But so it's just very like routine and systematic, like I said earlier.
Have you had an emergency situation where you've had to call EMS?
Thankfully, no, I really haven't. I have definitely had cases where I didn't like the way something was looking on the monitor, say like a weirder rhythm. And so the thankful thing too is, we can early on getting those monitors and things in place, I can assess that before we're completely asleep and intubated, things like that. And so I've had a few cases where I've canceled them and said, hey, maybe we should reevaluate, go see your PCP or a cardiologist or something like that, just to make sure everything's safe. And thankfully, and a lot of the time it is safe, and I know it's safe, but before it becomes something really bad, I would like to get it checked out. And so that's probably one of the biggest reasons I would say I've like canceled a case that I thought was maybe going to be more straightforward. And then the other really big thing is just people who they have eaten and not told us. And, I've had definitely kind of situations of people throwing up or kiddos, like, because the thing with the anesthesia mask is it's pushing that pressure towards your belly. And so at a certain point, you can cause that sphincter, sorry, I don't know a better term for it, but that kind of
Mm-hmm.
valve to open to where those stomach contents can come out. And so again, if that happens right when we're going to sleep, it's definitely going to be its own situation to handle. But we're not going to proceed at that point, you know? And so I would say that the heart rate and if people like kids seem sick. So the like kind of recent illness history, we kind of touched on that, but if you were recently sick within the past typically month or so, it can cause there to be a heightened reaction in your airway where there's more like inflammation. And so that can pose more risks under anesthesia. And so sometimes we listen to the hearts, the lungs, and everything sounds fine. And then once we go back, I might hear your kid cough or kind of see more green mucus than I'm anticipating. And then I'm like, you know what? Especially because I've been doing this so long, I am at the point where I'm like, I have seen this before, and I know that it doesn't go as smoothly and straightforward as I would like. And so it's always a hard conversation because it's frustrating for everybody. But again, it is like in the best and safest interest of our patient. And so those would be the biggest things, which again, like I said, thankfully there's not been anything. Just the other times would be like that medicine that we give beforehand, of course, can sometimes have the opposite reaction and kids get really hyper and really wild. And so there's things like that. But again, those are all things we expect, anticipate, or are prepared for in the event.
They don't phase you too much.
Oh, yeah, not, no, thankfully, maybe at first, but not so much now.
So you're not typically going to sedate somebody who's in day one or day two of a really nasty cold.
Absolutely not. Like I said, we do really try to wait a month. The studies typically say about 4 to 6 weeks from the time the symptoms go away. So it's not even from day one, you know? And so that is the toughest thing with kids, especially because they get sick all the time and might be right at that cusp of the 4 week mark and then are now entering into another cold. And so it can be really difficult for parents, frustrating. And I understand, of course, we want to take care of their teeth. However, again, it is a big enough risk that it's one of those times the risks outweighs the benefits of trying to get the teeth fixed at that time. And so um, we will, especially even day up, if your kid could have been healthy for the past year and then, of course, the day we have our anesthesia plan, wake up coughing, drainage, things like that. And unfortunately, it's just not a very safe time to proceed. Of course, in the hospital, I think there's the true emergent type situations where it does have to happen. And that's a totally different situation, different setting. And so sometimes people ask, like, well, if they were in the hospital, what would you do? And I'm like, it goes into what's an emergency versus something that's more elective. And most of what we do does fall into that category of more elective type procedures where we do unfortunately just have to wait.
Yep, absolutely. Last question. I want you to answer it and then I'll answer.
Yeah.
If you had a child who needed dental work done that they could not handle awake, would you feel like it's safe for your child to do anesthesia in the dental office?
I would. I have had nephews get anesthesia in an office setting, not necessarily dental, but um, and I get that question from a lot of people with young children. I have nieces, nephews, things like that, and so they often ask me, and I always tell them, I'm like, if you want me to do it, I could do it for, a little bit like friends, kids, and things like that, and I would feel completely comfortable doing that. And so I always would say, like, if it were my best friend's child, I would put them to sleep without any issue or concern, I guess, for being able to do it safely. Or like I said, my own family, it's I would call one of my colleagues and say, hey, like, we got to get this done. Would you mind being the one to do it? And so like I said, I think when it's a young or a healthy patient and kind of a more routine case, 100%, I think you can do that safely. And
As a mama of two teenage girls, and we've done a couple of surgeries and a couple
Mhm,
of, and we've done an oral surgery
mhm,
before. And so I can say I 100% feel the angst that parents feel.
Yeah.
And they're not easy conversations to have with a mom in my office when we're doing that consult and we're talking about the pros and cons of sedating versus not sedating. I completely understand it. Um, it's never my first choice to do anesthesia. I always want the child to have a good experience and do it awake and with as few medications or interventions as possible. But there is definitely a time and a place. Um, we didn't do we didn't have any like traditional dental work when my girls were little, but as a teenager, we had a pretty decent oral surgery procedure, and I was a wreck. And I was pacing back and forth in the office. I did not do the procedure or the sedation or any of it. I was in the waiting room because I was mom that day,
Oh,
and I
yes.
paced back and forth. It knowing exactly what happens and knowing that they had her best interest at heart, um, knowing that they knew me and so they knew they'd have to deal with me if anything did go wrong.
Yeah, exactly.
As hard as it is as a mama, yes, I would do it again. And I feel like it's safe, it's predictable. And the reason that these tragic stories make the news is because they are so rare and it's so shocking.
Mhm.
Because it should not happen. Accidents in the dental office like that, tragedies in the dental office like that should not happen. So yes, 100%. I feel like it's safe.
Oh, yeah. And thankfully, again, the training has greatly expanded, I think. Like now it's an actual recognized dental specialty to do dental anesthesia. And so that has helped increase the safety of doing it in the office, as well.
For sure. Awesome. Well, thank you so much, Dr.
Oh,
DeFreitas.
yes, it's been a pleasure. Thank you for letting me chat away about it. And hopefully, I've answered a lot of people's questions and concerns and helped alleviate some of those fears. Because, again, I do totally get that it's not a fun day for anybody, for mom, dad, kiddo. Like, it's definitely not anybody's first choice, but we're there when we need to be, and we're there to make it as easy and stress-free as possible, and get everybody through it safely.
That's right. Awesome. Well, thank you so much. We
Yes,
really
thank you. Of course.